Assalamu alaikum, good morning, good afternoon, and good evening, depending on your time zone. We're going to move on to our next lecture. So if anyone knows how to do the slideshow, let me know right now so that we can have it a bigger slideshow, maybe this here right
Prof, yeah, you can click that slide. So,
slideshow, right?
yeah,
Okay.
there is play from the start. You can do that, or
Play from start, right?
the below one,
Section,
the green button.
the green button.
Below the home, Prof.
Oh, play from start. Okay, from here, right? Okay, good. All right. Okay. So, as promised, we are going to cover fracture and dislocation. Very commonly tested, regardless of which exam are you preparing for, whether it is MCQ1 or NACOSKI. So you will definitely get a case or a station from the dislocation and fracture. So recognize classic. These are the MCQ1 test. What we have to know is to recognize the classic clinical patterns from the mechanism, limb position, pain location, and function. Choose the safest first investigation, which usually it might be X-ray. Then, if you have to escalate it, MRI, CT scan when X-ray is negative or insufficient or inconclusive. Identify the red flags, neurovascular compromise. Obviously, we have already discussed it. Open fracture, treatment, scan, dislocation, inability to bear weight. This is very important. Inability to bear weight. Know when conservative care is appropriate and when urgent orthopedic referral is required. Avoid distractors. So in this scenario, whatever scenario that you get or in the station, there might be a few things to distract you from the real um, clinical vignettes or the real diagnosis or the real investigation or their management. So you need to be able to recognize that to avoid it. Okay, unnecessary MRI, delayed follow-up, steroid injection, antibiotics for the closed injury. 5 diagnosis, 1 MCQ, 1 logic. So hip fracture, very important, most commonly tested in licensing exam. Usually with a hip fracture, if they test you, they will give you a scenario about somebody who is an elderly, someone who is above 60 or 65, and the patient has falling disease or a history of a fall, groin pain. So elderly after a fall, developed groin pain, cannot bear weight. And just to help you out, they give you shortened externally rotated leg, which is hip fracture. Scaphoid fracture. So if they want to test you on this one, it could happen to anyone, children, adults, elderly. So fush or falling on the outstretched hand, snap walk tenderness, very important characteristic finding. Normal initial X-ray. So if you have a normal X-ray, which is the initial investigation for suspected fractures, right? So if you have a normal, especially for the scaphoid, if you have a normal X-ray, it does not exclude the scaphoid fracture. So it means you need to immobilize Thomas Spiker and ask the patient to come back in 10 to 14 days. Remember this, 10 to 14 days to repeat the X-ray. The next X-ray will show the fracture, if there is a fracture. I will go dive deep a little bit more in scaphoid fracture because this is very commonly tested. So you need to know a little bit more about it, about the location, when it happens in the distal, proximal, and medial. what are the complications and why it's important to have a follow-up imaging. So let's say that you have a patient. So let me move on and then we will come back to the scaphoid fracture. So, but just remember that if you are suspecting a scaphoid fracture, but the initial X-ray is negative, it doesn't mean it is not a scaphoid fracture. If you have snuff box tenderness, it is good enough. It is good enough to diagnose it and put a time spiker and follow up in 2 weeks. So you might get 10 to 14 days or 2 weeks. Either one is fine. Sometimes they give you an option of follow up the patient with a follow up imaging in 10 to 14 days, or it might be in 2 weeks. Either one is fine. Ankle injury. Apply Ottawa ankle and foot rules before ordering imaging. Shoulder dislocation. Anterior is most common. Anterior is most common when it comes to shoulder dislocation. If they're asking you which one is more common, go for anterior shoulder. Posterior is missed after seizure or electro caution. So usually for somebody that who is exposed to electricity or who has experienced seizure, posterior shoulder dislocation is very common. It doesn't mean that we don't have anterior shoulder happening after seizure or electrocution, but the posterior is very, very commonly happening after seizure and electrocution. So remember that if they want to test you on posterior, they will mention seizure or electrocution, but for anterior, they usually mention sport, injury, and repetitive trauma. Clavicular fracture, most mid shaft fracture are conservative, but the skin tinting, this is very important. An unstable distal fracture needs urgent referral. So remember the skin tinting. We are going to go dive deep into every single one of them. Hip fracture, classic MCQ1 presentation. So think hip fracture until proven otherwise, in which cases typical patient will be elderly, as I mentioned before. For the hip fracture, if they want to test you, usually they will give you someone who is elderly, who has osteoporosis, who has frailty, who has fragility, and who is prone to falling disease, who has history of falling disease. So older adult, low energy fall or frailty related trauma. So the key clues, growing pain. After the falls, they will develop growing pain and the patient will have inability to bear weight and the legs will be shortened and externally rotated. Okay, so initial test, what do we do? X-ray. Usually for the fracture, the initial test will be X-ray. So anterior posterior pelvis and lateral hip X-ray. If X-ray is negative and you're still suspicious of the pelvic fracture, do hip MRI of the hip for occult fractures. Hip fracture exam decision. So the clinical situation, classic deformity after fall, which I did mention it to you guys, it will be shortened, externally rotated, and the patient will not be able to bear weight. So what do we do? Anterior posterior pelvis, lateral hip X-ray. Starting with the MRI before X-ray is the trap. We never do MRI before X-ray. Always the best initial is X-ray. But if X-ray doesn't help and you're still suspicious of the pelvic fracture because the patient has all other clinical feature that matches the criteria for hip fracture, then you can go ahead and do the MRI. But we never prioritize MRI to X-ray as an initial investigation. Normal X-ray but cannot bear weight, now you can do hip MRI. Reassure is an trap, a distractor. Don't do it. Displace or older adult fracture, operative management, bed rest or outpatient follow-up is a trap. Don't do it. So if the patient has displaced fracture, always needs operative management. This is also, you can also say that it is one of the emergency because the pelvic fracture, the patient will die due to hemorrhage than the tissue damage in the pelvis. So that's why if you are suspecting pelvis fracture, because there is a cavity and there's a chance of bleeding in that cavity, like an abdominal cavity, and the patient may go to the shock and the chances of dying is very high. So you don't want to take the risk and discharge the patient, right? So you need to do operation. So severe pain plus confusion, adequate analgesia, avoid opioid entirely. So remember, for severe pain and confusion, we always ask the patient, provide the patient with a painkiller. We do not push through the pain. If the patient says, I have pain, and still I'm like, just give me a few more minutes, I need to finish this history taking, or I just have to finish the consultation. No, so regardless of whatever it is, we need to take care of the pain because pain what triggers everything, the confusion, the delirium, this and that, all the complication. So we need to take care of the pain. We have to provide enough and adequate analgesic so that the patient can give us a proper history, support us during investigation or physical examination, or he will be in a better position to talk, not to be distracted. And low energy fragility fracture, osteoporosis plus fall prevention, treating surgery as an endpoint. So the last part is the trap, don't do it. So hip fracture algorithm. So from A to, from 1 to 5, what do we do? First, recognize. How do we recognize it? So all those characteristic finding, for example, the patient is an elderly, the patient has history of a fall, the patient developed growing pain, the patient has no ability to bear the weight, the limb is short and externally rotated. So this is how you recognize the hip fracture. Elderly, fall, or trauma, any sort of trauma, right? And then the patient cannot bear weight or stand, and then the patient a limb on the affected side is short and externally rotated. So this should give you a clear characteristic picture of hip fracture. Okay, so now I have it clinically. I have to move on and confirm it with the imaging. What should I do? Anterior, posterior, and lateral imaging. What is the initial imaging? X-ray. So let's say that I'm still suspecting my patient has all these characteristic find of a pelvic fracture, but X-ray doesn't show anything. What is my next option? My next option is to do MRI. Now, MRI, if the X-ray is negative, but suspicion remains high, it means I have this, I have all of this, but this is inconclusive. So I do this. Now, stabilize the patient. Always we stabilize the patient. We take care of the pain. Remember, pain will cause a lot of other issues. We have to take care of it. Hydration, delirium prevention, VTE plan. And then we move on to the definitive treatment. For the pelvic fracture, the definitive treatment is orthopedic repair, plus rehabilitation, and plus osteoporosis care. I think I have a bigger picture of this. Let me see. Yeah. So when it comes to pelvic fracture or hip fracture, sorry. So femur, neck, greater trochanteric, lesser, intertrochanteric, and subtrochanteric. In terms of anatomy, and these are the picture for the lesser, for the greater, for subtrochanteric, and intertrochanteric, neck fracture, and subcapital. And these are the the management or the surgical management, typically for every single one of them, how to do it. So for the MCQ one, they might ask you, they might give you a picture of a hip fracture, and then they give you one of these options, that which one is the best surgical option for this specific fractures. And you should be able to tell that which one is which. So this one you have it in your notes. What else is important here? I think I did mention everything else. Okay. Scaphoid. A scaphoid fracture, uh, normal X-ray does not safely exclude it. So the reason I insist on a normal X-ray, because it has been commonly and repeatedly tested question. They give you a scenario about somebody that who had a fall, and then the patient developed wrist pain, snuff box, tenderness, and after that, the patient had gone through the imaging, and the imaging came back normal. So, what is the next step? Immobilize and repeat the X-ray in 2 weeks or 10 to 14 days. So, the mechanism is usually the foch, which is fall on outstretched hand, often in young active adults, but it could happen to anyone, and elderly as well. Key exam, anatomical snuff box tenderness. Very, very sensitive finding or characteristic finding. Scaphoid tubercle, tenderness, axial thumb compression, pain. But out of all of them, they usually commonly use the anatomical snuff box tenderness. Initial imaging, like always, it is going to be the X-ray with a scaphoid view. If X-ray negative, but still remains highly suspicious, Thomas Pica, immobilize, plus repeat the X-ray. Or if the X-ray is not available, let's say you want to repeat the X-ray, but the X-ray is not available, MRI is there, CT scan. Complication, or you don't have this option. For example, the patient has, for example, I'm giving you a scenario. You had a patient, let's say 24 years old. He is a volleyball player. The patient had a fall. The patient developed wrist pain, and also the snap back tenderness is positive. The patient went through the X-ray, and the X-ray came back normal. The physician has applied the splint, Tempus spica, and asked the patient to come back in 2 weeks. Now the patient is in your office or in the hospital, but you don't have any X-ray available for the next, let's say, 2, 3 months. It is not going to be available. So, or what is your next step? So, in the next step, you don't have any X-ray. If you have X-ray, that will be your choice. If you don't have X-ray, then either the X-ray or you need to do the MRI. So complication, non-union, I will tell you why it happens: proximal pole avascular necrosis and scaphoid non-union advanced collapse. So scaphoid fracture location matters. Location matters. So this is the scaphoid bone, right? So this is the distal. This is the distal fracture, which best healing. Distal pole, best blood supply, best healing. Best healing, why? Because it has the best blood supply. So usually conservative, if not displaced. We usually do a conservative treatment. We just immobilize it. Waist. What if it happens right at the waist of the scaphoid, which is the very common site? Intermediate healing, because the blood supply is less than distal pole. Immobilize and follow up until union. So union has to happen. And if you don't immobilize, then the chances of non-union is very high. And the proximal, which is this part, proximal pole, highest vascular necrosis. Why? Because blood supply is very high in the distal pole, less in the middle or waist, but it's very less in the proximal. That's why it is prone to a vascular necrosis. Lower threshold for the specialist care. Displaced fracture. If it is displaced, high non-union risk, open operation operative fixation. So if it is displaced fracture, then you have to do operation to fix it. Why? Because the chances of being non-union is very high. Occult fracture, initial X-ray may be normal. Thumb spica, repeat the advanced imaging, as I mentioned before. So scaphoid, these are the distal, waist, and proximal, and this is the snap box right here. All right. So the algorithm, you suspect. How do you suspect? You have a patient who had a fall, young patient, athlete, had a fall, wrist pain, and a snap box tenderness, radial wrist pain, snap box tenderness. Now you suspect. Why? Because it is characteristic clinical picture of a scaphoid fracture. So what do? I have to do anterior, posterior, lateral, and scaphoid, wrist, X-ray. Okay, what is next? The next is to do a follow-up. The next is to do a follow-up. But what if the X-ray is negative but suspicious? So if I'm suspicious, then the X-ray comes back negative. It's still, I immobilize the patient. I put a thumb spica for the patient and ask the patient to come back in 2 weeks, 10 to 14 days for the X-ray or MRI or CT scan. If displaced, proximal non-union, persistent pain or instability, I have to refer to specialist or involve the specialist. Ankle fractures and sprain, Ottawa rule. Imaging only when criteria is met. Ankle X-ray, malleolar zone pain, plus malleolar bony tenderness or inability to take or bear 4 steps in emergency room. Let's say you had a sprain or you had, for example, trauma. Now you have malleolar zone pain and tenderness, and you cannot walk for 3 steps in the emergency room. So you're a candidate for X-ray. So for the foot X-ray, mid-foot pain plus navicular or base of the fifth metatarsal tenderness or inability to take 4 steps in the emergency room. Same thing like the ankle. Simple sprain, functional care with early mobilization, compression, analgesic, and rehabilitation. High ankle sprain, external rotation injury. Remember this, for the high ankle, for this part, for high ankle, the patient will have a history of external rotation, pain above the ankle, syndesmotic tenderness, positive squeeze test. We're going to go through all of them. Unstable fracture, bimalleolar, trimalleolar fracture, talar shift, dislocation, neurovascular compromise. Okay, so the presentation. Lattice swelling, can walk, no bony tenderness. So lateral swelling. The patient had a sprain. The patient had twisted his ankle. And now the patient has lateral swelling. The patient can walk, no bony tenderness. Do I have to do? Can I do the X-ray? Simple lateral sprain, functional care. You don't need to do an X-ray. Why? Because it is just a swelling. The patient can walk. There is no bone tenderness. If the patient has malleolar pain, posterior malleolar tenderness, and the patient cannot take 4 steps, cannot walk on the affected side, 4 steps. Now the patient can do an ankle X-ray. If the patient has trauma in the foot, the base of fifth metatarsal tenderness, the possible foot fracture, and now we can do foot X-ray. External rotation, syndesmotic pain, it is high ankle sprain, immobilized, assess instability. Bimalleolar fracture, prestaral shift, unstable. If it is unstable, do surgery. So the algorithm, assess deformity, open wound, pulse sensation, ability to bear weight. Does the patient have the history of trauma or twist or sprain? Is there any deformity? Is there any pain, tenderness? Is it in the malleolus? Is it in the navicular? Is it in the base of the fifth metatarsal? And does the patient have the ability to take 4 steps? Based on that, you decide. Apply the rule of Ottawa for fourth criteria for imaging. X-ray if needed, plain radiography first, CT scan for selected complicated or complex fracture. Treat the sprain, functional care early, range of motion strengthening, return to activity plan. Refer urgently if there is a dislocation, if there is a talar shift, again, dislocation, unstable fracture, neurovascular compromise. Obviously, if there's a neurovascular compromise, then we have to refer. All right. So let me see. I think I have another. No, not here. I know I do have another one, but don't know if I put it here. But anyway, so for the X-ray, the malleolar, medial, and lateral malleolar supposed to be tender, and also Ottawa ankle rule when to order ankle X-ray. So order ankle X-ray if there is a pain in a malleolar zone and in any of the following: bone tenderness at the posterior edge or tip of the lateral malleolar, bone tenderness at the posterior edge of the tip of the middle malleolar, unable to bear 4 steps. Usually they mention this 4 steps in the emergency room, so please remember this. For the foot, this area, mid shaft area, midfoot area, the navicular, the base of the fifth metatarsal, if it is tender or navicular fracture, then or the patient has pain in this area, this is an indication for X-ray. So order foot X-ray if there is pain in the midfoot zone, bone tenderness at the navicular, bone tenderness at the base of the fifth metatarsal, or the patient cannot take 4 steps in the emergency room. So must not miss red flags: gross deformity or dislocation, open fracture or skin tinting, neurovascular compromisation or compromise, severe swelling, compartments concern, or inability to safety examine. High clinical suspicion despite the confusing story or distracting injury. Tools, I think we mentioned everything here. Shoulder dislocation, anterior versus posterior. The arm position is the clue. Anterior, most common, this is very important. And the mechanism is usually if somebody abducted or externally rotated the arm, so the patient will have abducted arm and externally rotated arm, square off shoulder. For the posterior, usually they give you a trigger like seizure, electrocution, or alcohol-related trauma. Arm will be usually abducted and internally rotated as opposed to abducted and externally rotated, which is for the anterior. And never forget axillary nerve. Remember, for the anterior shoulder dislocation, they might ask you for which nerve is going to be affected. It will be the axillary nerve, lateral deltoid sensation and deltoid contraction, management, radiography, reduction, analgesia, sedation, post-reduction, X-ray, repeat neurovascular exam. Obviously, we do it for all the dislocation. Older adults, persistent weakness after reduction. If there is a dislocation and you reduced the dislocation, but the patient still have weakness after reduction, it means that the rotated calf is teared. Remember, tendinopathy, the patient will have pain. Tear, weakness. Tendinopathy, the patient usually, the main or chief complaint will be pain. But if there is a tear, then there will be weakness. These two different words, different condition. Just remember, sometimes IMG gets confused to go after tendinopathy or go after the tear. Tendinopathy, pain and stiffness, tear, weakness. So pay attention to the wording. Weakness, tear. Okay? Features, frequency. Which one is more frequently happening? Is it anterior or posterior? The anterior is more common. Mechanism, abduction and external rotation can cause anterior shoulder dislocation. Seizure, electrocution, internal rotation force cause the posterior. Arm position, slightly abducted and externally rotated for the anterior. Adduction internally rotated for the posterior. Important nerve, axillary nerve, full neurovascular examination for posterior. Imaging pairs, anterior posterior Y axillary view CT, F, anterior posterior saddle. Okay. This is the anatomy. I'm pretty sure that you guys know that. This is the anterior shoulder, which is posterior, which is going to be happening externally, anterior rotated and adducted. This one will be externally rotated and adducted. So I have to change these two. Okay. Shoulder dislocation algorithm. So before reduction, what do we do? Analgesia, sedation. So before we do the reduction, we have to make sure that the patient is under, if it is a big joint, the patient is sedated completely, or if it is something that we can control it, or the patient is okay with the analgesia, we give him analgesic. X-ray, when appropriate, document the neurovascular system. Reduce close reduction technique appropriate to direction. After direction, what do we do? Repeat the X-ray to confirm and assess the fracture and recheck the neurovascular system. So X-ray before reduction, X-ray after reduction. Check a vascular system or neurovascular system before reduction and check the neurovascular system after reduction. Follow-up, we do the sling, rehab, recurrence counseling, CAV assessment in older adults. Clavicular fractures, location, scan, neurovascular exam, the side wrist. Most common side, middle third of the clavicle. So they might ask you, so medial, 1/3 medial, 1/3 medial, middle, and lateral. So they might ask you which part of the clavicular is more prone to fracture. Is it the lateral, the medial, or the middle? Middle is 80%. The second most common is the lateral, and the last one is the medial. Okay? So most common side is the middle third of the clavicular. If you split the clavicular in 3 parts, the middle part is 80% fracture. So most common side. Again, like any other fracture, the initial test or imaging will be the X-ray. Consider the chest assessment after high energy trauma. Why? Because if it is middle, if it is distal, usually the chances of pneumothorax is very high. Most close minimal displaced, mid-shaft fractures, sling, displays mid-shaft fracture. Sling, analgesia, early range of motion as pain improves. Urgent referral if it is open fracture. Skin tinting, the very important to remember. Neurovascular injury and severe displaced shortening. Not only pneumothorax, it is if it is the medial area, and if it is displaced fracture, there's chances of rupturing the aorta as well. So pneumothorax, aorta rupture, these are very common and very fatal complications. Distal third displaced fracture with a uh, coraco-clavicular ligament injury is unstable and often operative. Clavicular fracture, conservative versus urgent. Okay. Closed, minimally displaced midshaft. Stable common pattern, sling and analgesia. Skin tinting, very important, very commonly tested, very commonly mentioned, threaten open fracture, urgent orthopedics. Open fracture, contaminated fracture, antibiotic plus urgent care. Distal fracture with clavicular disruption, unstable pattern, again orthopedics, fixation likely. Dyspnea, decreased breathing, possible pneumothorax, chest assessment urgently. So, finding, meaning, and management. If it is closed, minimally displaced midshaft, is stable and it means a stable common pattern. It's very common, right? 80% of the time. We do the sling and analgesia. If it's skinned, this is not common. This is threatened to open fracture. We have to do the surgery. Open wound, contaminated, obviously we have to do the urgent care and IV antibiotics supposed to be started. And also based on it is contaminated tetanus assessment. Distal fracture, if it is disruption, unstable pattern, orthopedic fixation likely. The chance of complication, fatal complication is very high. Dyspnea, decreased breath sound, pneumothorax. Cross-cutting red flags, neurovascular compromise, absent weak past cold, pale limbs, delayed capillary refill, numbness, motor weakness, open fracture or threatened skin, antibiotic, tetanus if open, urgent orthopedic involvement, dislocation with deformity. Reduce urgently if perfusion is compromised, then reassess neurovascular status and ability to bear weight after trauma, fracture, until proven otherwise in the right context, persistent severe pain, despite negative x-ray, think occult fracture or unstable soft tissue injury. So best initial investigation. Now, rapid review. What should we do? The best initial investigation. Just to make it very simple, for all of them, the initial best investigation will be the x-ray. If it is hip fracture, scaphoid fracture, ankle trauma, shoulder dislocation, and clavicular. But for ankle and foot, the patient has to meet the criteria. For example, mallular, medial and lateral, pain, tenderness, can not able to walk 4 steps. For the foot, the same thing. Other than that, the rest of them is X-ray. So for the hip fracture, if X-ray is negative and we are still highly suspicious of the hip fracture, then we move on to MRI. For the scaphoid, if it is negative, it's okay. We do the thumb spica and then repeat the X-ray in 10 to 14 days, or we do MRI and CT or CT scan. Ankle, again, it should meet the criteria. Shoulder dislocation, we do the shoulder, we do the X-ray reduction, we do the X-ray, we do the neurovascular system check, and then we do the reduction, and then we do the neurovascular and the X-ray after. The clavicular fracture, obviously we do the X-ray. MCQ strategy, what examiner is testing. Do not be falsely reassured by normal X-ray when the clinical picture is a high risk. Let's say they gave you a picture of someone who has all the characteristic finding of a scaphoid fracture, but the X-ray, the initial X-ray is normal. They want you to know that still you have to immobilize. They want you to know that still you need to do the thumb spica and do a follow-up X-ray. It is okay to get a normal initial X-ray for a scaphoid fracture or any other fracture, especially for the scaphoid. Okay? So they expect you to know this. And they will trick you based on that. So they give you a normal X-ray or an actual X-ray for scaphoid, and they will say like, just discharge the patient is okay, tell the patient to sleep it off, this and that. So we have to do or apply the thumb spica and ask the patient to come back for the follow-up imaging. Do not choose a steroid injection, massage, or routine follow-up when fracture dislocation has red flag. We don't do that. It makes the infection worse, right? Massage make it worse if there is infection, and we just rely only on massaging and a steroid injection or routine follow-up. Or if it is a dislocation, obviously it will cause the patient to lose the limb. Do not give antibiotic for closed and complicated fracture. Reserve the antibiotic for open fracture or infection. Use the exact anatomy, hip, groin, snuff box, malleolus base, fifth, shoulder position, clavicular skin tenting. Always reassess and document neurovascular status before and after reduction or immobilization. Final high yield take home points. Hip fracture, X-ray first, MRI if occult. If the X-ray is not conclusive, but still you're suspicious, MRI. Surgery, analgesia, delirium prevention, osteoporosis care, scaphoid fracture, immobilize if suspicious even. When X-ray is normal, prevent avascular necrosis and non-union. And that's why we do the thumb spica, to prevent avascular necrosis and non-union. This might be a question that why do you still have to do the thumb spica or immobilize the patient? Why? The X-ray is normal. Why do you want to do this? Your answer will be to prevent a vascular necrosis, or there will be another option to prevent a non-union. Ankle injury, other rule guide imaging, unstable fracture and talar shift, need orthopedic surgery. Shoulder dislocation, anterior is more common, but posterior after seizure and electrocution is very common. Repeat neurovascular exam after reduction. Clavicular fracture, sling for most stable mid shaft fracture, urgent referral for the skin tenting, open fracture, neurovascular injuries, unstable distal fracture, or thoracic sign. Here we go. We did finish it. All right.